Next is Dr. Aron Janssen. Dr. Janssen?
Thank you for allowing me to address the Joint Board of Medicine and Osteopathic Medicine. My name is Aron Janssen, and I am a board-certified child, adolescent, and adult psychiatrist, and an expert in the field of mental health and gender youth. I received my medical degree from the University of Colorado School of Medicine, and I completed my residency in psychiatry and fellowship in adolescent psychiatry at New York University Langone Medical Center. In 2011, I founded the Gender and Sexuality Service at New York University, a clinical service to children and adolescents with dysphoria. In my last 5 years at NYU, that clinic served over 200 families with multiple referrals each week. I'm currently the vice chair of the Pritzker Department of Psychiatry and Behavioral Health and chief psychiatrist of the Gender Development Program at Ann and Robert H. Lurie Children's Hospital of Chicago. I'm also an associate professor of child and adolescent psychiatry at Northwestern University Feinberg School of Medicine. I maintain a clinical practice in Illinois where I treat patients from Illinois and surrounding states. I have treated children and adolescents with gender dysphoria for over 10 years. I've treated over 500 children and adolescents with gender dysphoria during my medical career, and approximately 90% of the patients in my clinical practice are transgender children and adolescents. I am the chair of the American Academy of Child and Adolescent Psychiatry Sexual Orientation and Gender Identity Committee, and have served on the Transgender Health Committee of the American Psychiatric Association. I'm also a contributing author to the Child Chapter and Adult Mental Health Chapter of the 8th version of the World Professional Association for Transgender Health Standards of Care, which I refer to as the WPATH SOC, for the health of trans and gender diverse people. The WPATH SOC, first published in 1979, provides clinical guidelines for health professionals based on the best available science and expert professional consensus after careful and robust discussion, review, and comment that took many years. The WPATH SOC has been recognized and adopted as the prevailing standard of care by the major professional associations of medical and mental health providers in the United States. In addition, I've written numerous peer-reviewed journal articles and chapters in professional textbooks about the treatment of gender dysphoria in children and adolescents. In 2018, I co-edited Affirmative Mental Health Care for Transgender and Gender Diverse Youth, a clinical casebook, which is the first clinical casebook on mental health treatment for children and adolescents with gender dysphoria. I'm an associate editor for the journal Transgender Health and an ad hoc reviewer for journal LGBT Health and for the journal of the American Academy of Child and Adolescent Psychiatry. Each of these is a peer-reviewed medical journal. I'm actively involved in training other medical and mental health professionals in treating children and adolescents with gender dysphoria. I've conducted trainings for over 1,000 medical and mental health providers and have given dozens of public addresses, seminars, and lectures on the treatment of gender dysphoria in children and adolescents. The widely accepted view of the professional medical community is that gender-affirming care is the appropriate treatment for gender dysphoria, and that, for some adolescents, gender-affirming medical interventions are necessary. Gender dysphoria is a serious medical condition in which the patient experiences significant distress that can lead to impairment in peer and family relationships, school performance, or other aspects of life. Gender dysphoria is a formal diagnosis under the American Psychiatric Association's Diagnostic and Statistical Manual. Treatments for gender dysphoria have the same or similar level of evidentiary support as many other well-established treatment protocols in psychiatry and likely in every discipline of medicine. Treatment is individualized based on the needs of the child and the family and other psychosocial considerations and is decided upon only after discussing possible benefits and risks of both the intervention as well as the possible benefits and risks to not proceed with the intervention. Appropriate medical care, including mental health services, hormone therapy, and surgical treatment, can help alleviate gender dysphoria. Like non-transgender people, transgender people do not have a choice in their gender identity. Every person has a gender identity, which is not a personal decision or preference. A transgender boy cannot simply turn off his gender identity like a switch any more than a non-transgender boy or anyone else could. Increasing research, including prospective cohort studies, have pointed to the enduring and innate nature of one's gender identity. Living consistently with one's gender identity is critical to the health and well-being of any person, including transgender people. And efforts to alter one's gender identity to match gender assigned at birth has been proven ineffective and psychologically harmful. There is a reason every major mainstream medical association in the United States has spoken against conversion efforts, including the American Medical Association, American Psychiatric Association, and others, calling such efforts unhelpful, unethical, and harmful. The steps that make up a transgender person's transition into better alignment with their gender identity will depend upon that individual's medical and mental health needs. There's no specific step or series of steps a transgender person must undertake to complete their transition. Typically, transgender people start their transition with a series of steps commonly referred to as a social transition. These steps include changing their name, using different pronouns, wearing clothing, adopting grooming habits typically associated with their gender identity, and using the corresponding sex-specific facilities. Making these changes enable transgender folks to begin living their lives consistent with their gender identity and helps ensure that they are treated as such by family, peers, and others in the community. At the onset of puberty, some transgender young people also start taking puberty-delaying medication, known as puberty blockers, to prevent their bodies from developing unwanted and psychologically distressing secondary sex characteristics that conflict with their gender identity. Delaying any of these treatments, when they are indicated, will not only exacerbate a young transgender person's gender dysphoria, but could also lead to the development or worsening of other co-occurring mental health conditions, including depression, anxiety, and disordered eating. And importantly, in longitudinal research studies, accessing these treatments when appropriate improves gender dysphoria, improves appearance congruence, improves quality of life, and reduces depression and anxiety. Research and clinical experience repeatedly affirm that transition significantly improves the mental and physical health of transgender young people. This is true of each stage of a young person's transition, and transition can and often does alleviate co-occurring mental health issues a transgender young person experienced prior to transition. Following transgender or transition, transgender young people are often able to see significant improvements in functioning and quality of life. Mental health professionals use well-established, measurable, and objective criteria to diagnose and treat gender dysphoria. These criteria have been incorporated into the DSM-5 diagnostic criteria and are further honed by the ever-growing body of research. The standard of care for mental health treatment of gender dysphoria, also commonly referred to as the gender-affirming model of treatment, or gender-affirming treatment, requires a careful and thorough assessment of a patient's mental health, including co-occurring conditions, history of trauma, substance use, among many other factors. Therapists practicing consistently within the standard of care will create a space where the patient can explore their gender identity, knowing that being transgender and not being transgender are both equally acceptable outcomes. It is imperative that all individuals, including those with gender dysphoria, receive the optimal medical and mental health care they need and deserve. Denying the provision of such care for Florida residents who meet the requisite medical criteria puts them at risk for significant harm. Further, mischaracterizing the professionally accepted medical guidelines for treating gender dysphoria and the guidelines supporting evidence leads to confusion and a possible delay in needed care. If not treated or treated improperly, gender dysphoria can result in debilitating anxiety, depression, and self-harm. Further, eliminating access to evidence-based mental health care will make it even more difficult to retain and recruit child and adolescent psychiatrists who provide highly specialized medical care to Florida youth, including vulnerable infants, children, adolescents, and transitional-aged youth across the state with a variety of symptoms and diagnoses. Banning evidence-based mental health care is an overstep into the physician-patient relationship by interfering with personal medical decisions and individualized treatment plans best left developed between treating physicians, patients, and families. Again, thank you for the opportunity to address you today, and I look forward to answering any questions you may have.
Well, Dr. Janssen, thank you so much. The board members have any questions?
And the meeting is still muted, so I don't know if you're speaking now.
Yes, sir, Dr. David?
Unmuted.
Dr. Janssen, thank you so much for being with us this morning. Can you hear me?
It's quiet, so maybe if somebody is in front of the mic can repeat the question. Sorry.
Yes, sir.
Go ahead.
Let's try again. There we
Yeah.
go. Dr. Janssen, good morning. Can you hear me, sir?
I can hear you, yes.
Very good. Thank you so much for being with us today. We appreciate it very much. I have a couple questions for you so that I can better understand your position, and it does not necessarily belie my own. My chief question to you is this. As you well know, our colleagues in Europe were really the leaders in interventions in the treatment of minors with gender dysphoria decades ago. And as you may know, our colleagues in Europe now have seemed to take a change whereby in England, in Sweden, and Finland, they're now taking a more, I'm not sure what the correct term is, a more cautious or conservative approach. And I'm curious as to what this appears to me to be a paradox, whilst our colleagues in Europe are now becoming perhaps more conservative. Here in the United States, we're taking a different approach. I'm curious to your thoughts on that, sir.
Sure, it's a great question, and I can't speak to what the environment and the entirety of Europe is, but the part that I would emphasize that the best data that we have and the best
Muted.
longitudinal data we have on transgender youth comes primarily out of the Dutch clinic. Dr. Bix even referred to a lot of the Dutch studies and the Dutch model of care, and that's the prevailing model that most of the American clinics have based their care upon. There's no effort in the Netherlands to reduce access to care. And similarly, in the adult world, Belgium is really the place where there's the most longitudinal care and most longitudinal studies around transgender health and transgender mental health. And similarly, in Belgium, there's been no effort to divert or discern a different standard of care than the one that was put forth by both the Endocrine Society and the World Professional Association for Transgender Health.
Over the last couple nights, Dr. Janssen, I was reading Dr. Hilary
It's
Cass's...
muted again.
Unmuted.
Side things.
Let's try again. Over the last several nights, I had the opportunity to review the interim findings from Dr. Hilary Cass, and I'm sure you know Dr. Cass is a world-recognized authority on the subject, and she has been appointed as the chair of the Independent Review of Gender Identity Services for Children and Young People for England's National Health Service. And it's actually very interesting when I read the reports. They're actually very beautifully written. The language is beautiful in terms of the subtlety and the nuances of the language. And in the interim reports of the different items that we're discussing today, really the area that her team has focused on as the most problematic is that of pubertal blockers. And it's remarkable how humble they are in their admission of how little we know. In other words, many folks tell us how confident they are of their opinions, but there's concern after concern mentioned. So, for example, in the most recent letter dated July 19th, 2022 to Dr. Stewart, the National Director of NHS England, she mentioned how most of the data with the use of GHRH agonists in children were really focused on biologic males who had dysphoria, but she pointed out that this data does not necessarily reflect what we are seeing primarily today, which is the later presenting young people, particularly biologic females. So I'm just impressed how much more nuanced or perhaps how much more cautious they may be. And I'm curious as to your opinion on that.
Sure. I think it's important to know that there are a lot of ongoing research studies
Muted.
in today's context in the United States. There's a NIH study that's been prospective for the last 2 years, including 4 different sites, that includes the proportion of assigned females at birth and assigned males at birth that you are referring to. And there has been data released from those studies that has clearly implicated the value of puberty blockers. As an example, in one of the cohorts, the kids who had access to puberty blockers and were able to access them appropriately after an evaluation and assessment with that individualized treatment plan in place, had to diminish depression, anxiety compared to their transgender peers when accessing gender-affirming hormones. They had higher quality of life and significant improvements in functioning and body congruence. So we have this data in the US in the context in the past decade, in the past several years that we've been following. So I think that data is there. And I think it's important to know that the folks who are participating in this call today, that it's easy for us to talk about the studies. It's easy for us to talk about the policies, but it's also important just to recognize that the clinical work is really valuable. And the data that we have from our families and our patients who are telling us what is helping, what is working, how this has impacted our lives is also really important to recognize.
Thank you.
Unmuted.
Well, thank you, Dr. Janssen.